Hi and welcome back to another video of Medic Notes. This video is on gastric carcinoma. It is the third most common cause of cancer death in UK. 80% are more than 65 years old. Distal carcinomas more common in lower social classes and proximal tumors more common in higher social classes. 2 times more common in males compared to females. Etiology: 94% of gastric cancers are found in areas of gastritis. 10% of patients with pernicious anemia develop gastric cancer in young age. Risk of stomach cancer is 4 times greater in those who have family history. Environmental factors include diet, tobacco, and alcohol. Other risk factors are H. pylori infection, previous gastric surgery, premalignant conditions like gastric polyps, gastric ulcers, and hypertrophic gastropathy, Menetrier's disease. Site of gastric cancers: there is an increased incidence in proximal stomach, particularly around the cardia, and decreased incidence in distal stomach. This leads to increasing incidence of cancer around the GOJ, and it can be difficult to differentiate esophageal and gastric cancer. The Siewert classification of GOJ tumors. Type 1 is a true lower esophageal adenocarcinoma, usually arise from Barrett's esophagus. Type 2 is a true junctional tumor. And type 3 is an upper gastric tumor. Pathology of gastric cancers. 4 macroscopic appearances: malignant ulcer, with raised everted edges. Polypoid tumor, proliferating into stomach lumen. Colloid tumor, with massive gelatinous growth. And linitis plastica, caused by submucosal infiltration of tumor with marked fibrous reactions producing a small, thickened, contracted stomach. Whereas 4. Microscopic pathology. Tumors are all adenocarcinomas with varying degrees of differentiation. There is the Lauren classification, which classifies stomach cancer into intestinal type, with poor prognosis, composed of malignant glands, and the diffuse type, with better prognosis, composed of single or small groups of malignant cells. Gastric cancers can spread through local spread, lymphatic spread, commonly along the nodes of lesser and greater curves. Lymph drainage from cardiac end of the stomach may invade mediastinal nodes and then the supraclavicular nodes of Virchow on the left. At pyloric end, involvement of subpyloric and hepatic nodes may occur. Bloodstream dissemination, via the portal system of liver and then to lungs and skeletal system. And transcolomic spread, produce peritoneal seedlings and bilateral Krukenberg's tumors due to implantation in ovaries. Clinical features of gastric carcinoma. Local symptoms and signs are epigastric pain, vomiting, dysphagia, perforation or hemorrhage, and mass in upper abdomen. Metastasis features include jaundice, abdominal distension due to ascites, chest infections, bone pain, and enlarged liver or nodes. And general features are anorexia, weight loss, and anemia. For investigation, gastroscopy is the investigation of choice for diagnosis and biopsy. Other tests are CT scan and EUS. This is superior to CT for local staging of gastric cancer, and to assess lymph nodes and presence of direct invasion into adjacent structures. Management. Curative surgery is only for people without widespread metastasis. Principles of curative surgery: removal of lesion by partial, subtotal, or total gastrectomy. Removal of lymph nodes to a level determined by the site and extent of tumor. Restoration of continuity of GI tract. And creation of reservoir in case of total gastrectomy. Surgeries include partial or subtotal gastrectomy, extended gastrectomy for GOJ tumors, and total gastrectomy, performed for middle third tumors. Whereas for palliative surgery, the indications are obstruction, hemorrhage, and pain. Perform surgery only if it will significantly extend or improve quality of life. Procedure should be tailored to each patient's symptoms and wishes. Complications of gastrectomy. Immediate complications are chest infection, pulmonary embolism, or anastomotic leak. Whereas long-term complications, weight loss can be corrected by dietary supplementation. Vit B12 deficiency requiring injections. Iron deficiency anemia, malabsorption of fat and protein, and absorption of glucose increases, causing early hyperglycemia and late hypoglycemia. That's all for this video. Thank you.